From early learners to lifelong students, SDPB inspires curiosity through trusted educational programs and resources for every stage of life. Good, useful, and full of wonder. SDPB. When South Dakotans need reliable information, SDPB is there providing updates and coverage that keep our communities safe and connected. Good, useful, and
Good morning. We'll call Senate Health and Human Services meeting to order. Just a quick note, if you've noticed, Senate Bill 211 has been deferred. We moved that to Friday. There's a change on the agenda. I just want everybody up front to know that in case you're here for 211, that'll be heard on Friday. So I'd like to welcome everybody in the room, welcome everybody that's listening online, and those might be watching our new streaming service. Please, if you have your cell phones, please put them on silent or vibrate, just so we have no disruptions from cell phones in the meeting. Not really planning on any time constraints today on testimony, but we'll see how it goes. So we have the two bills today. With that, I'll ask the Secretary to call the roll.
Senator Grove.
Here.
Perry.
Here.
Reed.
Here.
Smith, excused. Voigt.
Here.
Davis, excused. Jensen.
Here.
Mr. Chair, we have a quorum.
Okay, thank you. With that, I would ask for a motion to approve the minutes from the previous meeting. Senator Perry moves to approve the minutes, seconded by Senator Grove. All those in favor say aye. Aye. Opposed, nay. Okay, the minutes are passed. So I want to remind everybody, if you're here to testify, please sign in on the iPad over here. If you're not familiar with that, one of the pages can help you with that. Otherwise, you can use a QR code over there and sign in on your phone. All testimony is now digital, so it shows up automatically on the log if you've signed in. So Again, lobbyists already know this. Have your proper credentials. If you plan to testify, introduce yourself and who you're testifying for. If you're testifying on your own behalf, please, when you come to the microphone, push the green little red button, make it green, and then introduce yourself and let us know if you're testifying on your own behalf. If you haven't signed up and you testify, please sign up, at least sign up afterwards so it's on the log. And with that, I'd like to have the pages come up and introduce themselves. And while they're coming up, if you have any handouts to distribute to the committee, please ask a page to do that for you. So yeah, who are you, where are you from, and do you have future plans?
Okay. My name is Rachel Stephenson. I'm from Arlington, and my future plans are to go to SDSU for elementary education.
I am Lee Decker, a junior at Stevens High School in Rapid City. I plan on going to law school after I graduate.
Okay, thank you. With that, we do have a presentation today, and I think it'll be at the end of the committee, about 15 minutes. Senator Davis is introducing a bill of her own in another committee, so as soon as she's back, if she's back, we will roll right into the second bill. Otherwise, we may do the presentation in between. So with that, we'll start with Senate Bill 87, clarify and establish requirements related to forensic medical examinations. Do we have any proponent testimony? Good morning, Senator.
Good morning, Mr. Chair, committee members, Tim Reed, District 7. And today I bring before you Senate Bill 87. And I do have an amendment. It's Amendment B, and I would appreciate it if you'd move it at this time.
Okay. Yeah, was that a B?
B as in boy.
Okay, thank you. So Senate Bill 87B, your amendment moved by Senator Voigt. Senator Perry, sorry, seconded by Senator Smith. All those in favor say aye. Aye. Opposed, nay. Okay, you can please present 87B as amended.
Thank you, Mr. Chair. This bill focuses on strengthening the pathway between hospitals, clinics, and sexual assault response teams when a victim of sexual assault presents themselves for care. In those first hours after an assault, two things must happen well. The victim must receive compassionate and appropriate medical treatment, and any forensic evidence must be properly collected and preserved. This legislation ensures hospitals have clear, written policies that outline how they coordinate with sexual assault response teams and law enforcement, whether exams are connected on-site or through a referral. And by establishing clear expectations in statute, then we create greater consistency across the state so that a victim can expect a similar standard of response regardless of where they seek care. Formalizing that coordination improves outcomes for victims, strengthens the integrity of the evidence that may ultimately be used in prosecution. So why is this important? A sexual assault forensic examination may not be the path to a 100% successful prosecution rate, but having the exam makes three things possible. It creates opportunity for a connection with the victim, making it more likely that the rape will be reported. Medically and psychologically, it provides benefits for the survivor when they receive trauma-informed, compassionate care. Number 3, it creates the possibility of a forensic yield, which makes it more likely an offender will be arrested and prosecuted. So I'll walk through the bill here. The first few pages of the bill, the first few sections were cleanup language as we work through it. But if you go to page 4, you'll see on the top that two definitions have been added. And that is what's a sexual assault nurse examiner, and then the sexual assault response team, a definition of what those are, and because that is that term, both terms are used now in the new sections. So section 6 is a new section, and what it says here in this section is there are really 4 people who can, or 4 roles within the clinic or the hospital that can perform a sexual assault forensic examination. That being a physician assistant, nurse practitioner, and a sexual assault nurse examiner. It goes on to talk about that these people need to be trained, and so the hospital or clinic needs to understand or needs to figure out what training that they need to provide that they should have for these 4 individuals. The 4th, the sexual assault nurse examiner, has already got quite a bit of education and training. It also goes on to state that you can use, they call it an e-SANE, so you can use telehealth for this. Then Section 7 goes on to talk about that there should be some policies and procedures regarding the administration of those forensic medical examinations. And one of the important things is just to state whether the hospital does or does not provide the examinations on site. We have areas in rural South Dakota that it is impossible to have the folks there that in the ER or in the clinic. And so, or I shouldn't say impossible as much as there's a big burden to get there. But as long as they say we cannot do these, then they'll go on to say, we will make sure that there's a timely transfer and referral to a location that does provide the examinations. And that's all just to preserve the integrity of the forensic evidence. You have a certain time period that you want to have that all happen. Plus, you don't want to lose the victim that presents themselves if this gets to be too long. So it has to be timely. Also in there, it makes sure that they're coordinating with law enforcement on the processing, storage, and maintenance of the chain of custody of any evidence that is collected. And really important in that section is it addresses how the hospital coordinates with a sexual assault response team that provides services to the county in which the hospital is located. Now, that's something that what that creates is a good pathway of communication. So if something went wrong, in a past situation or didn't quite go right, or maybe they lost a prosecution because of something, now they can start talking about how do we better respond to this, and the hospital will be part of that conversation. And then it also goes on to say that the hospital, to address how the hospital provides information to a patient requesting examination on the availability and resources from victim advocates. And so that's an important part also of this. So that's the policy and procedure that we're talking about to have the hospital do. Now, Section 8 just goes on to do the same thing for a clinic. Before, we're talking more about a hospital, but Section 8 does, if a clinic does this, they need to follow basically the same rules as a hospital. So where you live in the state should not dictate the service that a victim receives. We need to be more uniform across the state. And so that's what this legislation is also about. As rural as we are, there are shortfalls in areas, and we have to work towards fixing those shortfalls. But the ultimate goal is making sure victims that present themselves will continue with the examination and hopefully prosecution. So I ask for your support with Senate Bill 87. Thank you.
Thank you. Do we have any other proponent testimony? Good morning.
Okay, it's green. All right. Good morning, Mr. Chair and Committee. My name is Tracy Decker, and I'm here on behalf of myself as a proponent of Senate Bill 87B. I'm a resident of Rapid City. I'm actually a constituent of Senator Voigt in District 33. I'm also the mother of Lee Decker, the page. He's embarrassed now. I'm currently employed with the South Dakota Network, but I've actually spent most of my adult career as a prosecutor. For almost 20 years, I prosecuted sex crimes in both Pennington and Meade counties, crimes against women, men, and children. I've worked on thousands of these cases. And so I want to talk about this bill from my perspective as a former prosecutor and on the public safety standpoint. First, I want to acknowledge rape victims' medical well-being needs to be secured above all else. That's always the priority. But collection of evidence is and can be equally significant because people want science, jurors want DNA. Law enforcement needs evidence, prosecutors need evidence. Nobody ever wants to get this wrong. So this bill, why this bill? South Dakota, as Senator Reed said, is a rural state. It's a vast state. It's imperative that no matter where the assault occurs, that we have a plan to take care of victims and collect evidence for law enforcement. The expectations and requirements outlined in this bill ensure that providers statewide are prepared in some fashion to do their part, and the evidence is not being lost due to lack of services or lack of knowledge of the importance of this type of exam and how to do it. This law will help ensure that medical providers, law enforcement, prosecutors, victim advocates are talking through SART teams that can be developed and are already up and running in many parts of the state. It's well known that sexual assault is an underreported crime. I think that everybody acknowledges that. But we also know in South Dakota, we still have very high numbers. Consistently, Rapid City is listed as being number 2 or number 3 per capita in the nation for reports of rape by the FBI. And South Dakota overall is 10th in the nation per capita by the most recent report that is available on the Department of Health's website. And each step of that process, the numbers decrease. So reports are low. Those that can be investigated, if there's physical evidence, are even lower. Cases that are charged and prosecuted, that number decreases even more, and conviction rates are even lower. That's why physical evidence is so important. Sexual assault is one of the hardest for law enforcement to investigate and for the prosecution to prove, despite all of the efforts they put into it. I could share a lot of anecdotes about difficulties victims have faced around the state, but I'll just sum it up by saying sometimes distance is a factor, sometimes time, sometimes being told we don't do those here, and victims just kind of being left on their own. And what's difficult about that is sometimes when they walk out that hospital door, they never come back, they never tell anybody. So we don't get that report. Not only do we lose that evidence walking out the door, we lose the chance to help that victim. The first person who comes into contact with a sexual assault victim kind of sets the tone for the whole system. When the nurse and the medical providers are compassionate and knowledgeable and know what to do, that helps instill trust in the system. Because to a victim, we're all a part of the system. They don't differentiate between medical, law enforcement, prosecutor, it's all the system. And the best way to keep a victim on board with an investigation and prosecution is to treat them right from the very beginning. And consistent statewide practices will help with that, will lead to more evidence collection, which will lead to more potential for arrests and lead to more and better efforts at prosecution and overall better offender accountability. So I just want to say I do think this is about public safety as much as it is about patient care. With consistent policies and guidelines statewide, it won't matter if the rape occurs in Elk Point or Chamberlain, Parker, Groton, Sioux Falls, Rapid City, or Brookings. There will be standards in place for those injured, policies to collect evidence to assist holding accountable those that prey on the most vulnerable. So in support of public safety and offender accountability, I urge you to vote in favor of this bill, and I appreciate your time. And I want to thank Senator Reed for bringing this forward.
Thank you. Did you learn anything about your son you didn't know before? About his future plans?
I've learned a lot about him during this time.
Thank you. Any other proponent testimony? Good morning.
Good morning, Mr. Chair and committee members. Melissa McCauley, registered lobbyist for the South Dakota Network Against Family Violence and Sexual Assault. We're here today to strongly support Senate Bill 87B. We want to say thank you to Senator Reed for being a champion for looking out for domestic violence and sexual assault victims. This bill clarifies and strengthens the requirements related to forensic medical examinations for survivors of rape and sexual assault, ensuring that the costs are covered, the examinations are available at no cost to the victims, and that the appropriate procedures and trained examiners are used. It includes important provisions for minors and protected persons to consent to examinations and promotes informed care and coordination with sexual assault response teams. Senate Bill 87B improves access to critical medical and evidentiary services for survivors at the time when they most need it. And with that, we urge you to support this bill.
Thank you. Do you have any other proponent testimony? Good
morning, Mr. Chair, members of the committee, Tim Rave, Sadaho. I rise in support of the bill for all the reasons previously stated, but I really came up here to thank Senator Reed. He was very gracious and very patient with us, addressing concerns that all of my members, frankly, had about the implementation of the original bill. So I ask you to please support the bill as amended, and thank you, Senator Reed.
Thank you. Any other proponent testimony? Good morning.
Good morning, Mr. Chair, members of the committee. Lisa Gennaro with Concerned Women for America. I also sit on the West River Human Trafficking Task Force. This bill is very important, and I do appreciate Representative Reed bringing this bill. I'm actually going to have one of the pages, if you don't mind, just hand these out. It just kind of gives you a little more information on why we need this particular bill. And at that, I'm just going to say, I hope you vote yes on this bill. Thank you.
Thank you. Thank you. Do we have any other proponent testimony? I don't think we have any online. Is there any other proponent testimony in the room? Okay, seeing none. Do we have any opponent testimony? And none online. Any opponent testimony to Senate Bill 87B as amended? Seeing none. No need for rebuttal. I'll open it up to committee questions.
You said questions?
Senator Grove.
Thank you. I have a question for the prime. Okay, no, I lost the bill. So in section 6. Okay, so I live in a very rural area. I want to verify that I'm understanding this correctly. You mentioned telehealth. And so if we don't have all of the nurses with the titles and all that, we can still offer these services if you're a physician, physician assistant, et cetera, as listed on line 22. Utilizing telehealth, then we meet the requirements that this law requires, that we're good.
Mr. Chair, Tim Reed, District 7. Thank you for the question. Yes, it is important to note that a physician, a PA, a nurse practitioner that may not be fully trained, but can utilize telehealth to complete the sexual assault forensic examination.
I have a real quick one for the prime. In sections 2 and 4, we strike the word physician but leave hospital and clinic. I'm just wondering the rationale behind that.
Mr. Chair. Tim Reed, District 7. Let's restate the question again in which sections?
I think 2 and 4, I believe. Right at the beginning, it says it strikes physician.
Right.
Before it said each physician, hospital, or clinic, and now we strike the word physician. I'm just curious the rationale for that.
Sure, thank you, Mr. Chair. When we were walking through these sections and how they interact with the sections that we added, we realized that the physician is not the one. We switched it because it's about the location, not about the physician. And so we had hospital and clinic in there, and they weren't really the ones that were actually doing the examination. So it got confusing there, and so that's why we took physician out and said that this is about the hospital and clinic that provides the forensic examination, not who actually does it.
Thank you for that. Any other questions from the committee? Okay, seeing none, we'll close public testimony and open it up to committee action and/or discussion. Senator Perry.
I'll go with action. A do pass for Senate Bill 87.
Second.
Senator Perry moves do pass on Senate Bill 87B as amended, seconded by Senator Grove. Any comments on their motion?
Yes, sir. Mr. Chair, this act, is clarifying and establishing requirements related to forensic medical examination. And the senator that put this together and the team that worked with him did an outstanding job in making it very clear, and it's something that we should endorse.
Thank you. Any other comments?
Mr. Chair.
Senator Grove.
This is probably too personal for this early in the morning, but I feel like it's so. As a rape survivor who was told that it was my fault and I got absolutely no care at all and didn't ever report it to anyone, it is good to be in a position where I can stand alongside of this type of a bill and put my name on it and say, these folks need help. And I'm glad that we have procedures and policies that are for not just the big cities, but for the middle the middle part of the world too. So I'm glad about this bill. Thank you for bringing it.
Other comments? Okay, seeing none, so the motion before us is do pass by Senator Perry. Senate Bill 87B as amended, seconded by Senator Grove. All those in favor say aye, opposed nay. I'll ask Secretary to call the roll.
Senator Grove,
Aye.
Perry,
Aye.
Reed,
Aye.
Smith,
Aye.
Voigt,
Aye.
Davis excused, Jensen.
Aye.
Mr. Chair, we have 6 yeas and 1 excused.
Okay, thank you. Senate Bill 87B as amended, do pass motion to the floor. Is there any objection to consent? Seeing none, we'll certify 87B as amended for consent. Thank you. We'll probably have a little delay here waiting for Senator Davis to come back for this next bill. With your indulgence, we have a presentation that maybe would interest a lot of people in the room. It's about 15 minutes or so. If you're ready, we could go ahead and do that now while we wait for Senator Davis to return. So, and this is primarily a presentation for the committee, but it's good for everybody to hear.
Yep. Thank you, Mr. Chair. Again, Tim Ray with Sadaho. Appreciate the indulgence of the committee. I think you will find this interesting. Sadaho, along with several partners, received a state grant a year and a half ago, and we're in the middle of a 2-year grant trying to help support the EMS community. And one of the problems we as hospitals on the hospital side have is access to services that we're able or willing to transfer patients in a timely manner from facility to facility. So imagine, I don't know, I'm just picking on Gettysburg because it's the first town that comes to my head, but Gettysburg to Sioux Falls is about 4 hours. So if you're the EMS provider volunteering in Gettysburg, you do a turn to Sioux Falls, that's a full day. That's nine plus hours. I know that, having done it myself many times. So we were trying to find a way to have a repository where if that particular originating service couldn't or wasn't able to do a transfer in a timely fashion, they could put that transfer in, we had envisioned some kind of spreadsheet or something. And Todd's going to get up here and show you a really cool tool that we found with him and his organization. But we wanted a repository that the transfer that's pending from, I'll just in this case say Gettysburg, they're like, we can't go, we need to be in town, take care of the town, whatever, that they would then be able to, maybe one of the surrounding services would get a notification, say, hey, there's a transfer in Gettysburg, needs to go to Sioux Falls, anybody want to do that? So we wanted something that would alert them that, yep, there's going to be there's a transfer pending, and oh yeah, we're in a town close by. Yeah, we'll go do that. We'll take the revenue from the transfer. We've got time to do it today, etc. So we did got a grant from the state under the EMS monies that were out of the COVID monies, and so we looked across country, found a product that would fulfill that need. That product is, Todd back here is going to show you in just a minute when I step away, but our goal is to get every ambulance service signed up in the state that wants to. They don't have to, but we'd like to have everybody on board. And then if there's somebody across the state that wants to do that transfer, they can. So it'd be, our vision is a small cog in a big wheel of trying to help EMS in the state. But with that, Mr. Chairman, I'll stand down and let Todd take over.
Okay, thank you.
Chairman, Senate committee members, my name's Todd Sheridan. Thank y'all for letting me come and present this today. I'm going to go ahead and just take a second and get my screen shared here so everybody can see the presentation. Perfect. All right, so a little bit about Ride Central. Ride Central, yes, we've been working with Mr. Tim Rave and Mary Adams and the Sadaho team. They've been phenomenal to work with. Ride Central is a product where what we do is we connect all parts that have been transactional for years from the hospital organization to the ambulance companies and get all that data and make it transparent. The challenge point is, even before COVID, now with COVID, you think about all the hospital workers, the case managers, the nurses, the doctors, they're doing more with less, right? And what we didn't know until we started this product, that it took 30, 45 minutes, an hour sometimes for these caregivers just to order one ambulance. On the flip side of that, they're doing it all transactionally, a lot of paperwork, a lot of CMS rules and regulations. On the flip side, all the dispatchers that have to take the calls, enter all the information, those transactional pieces that are challenges in this ecosystem, we wanted to solve. And the way we did that was a caregiver on the floor integrating Right Direct in their patient care record system like Epic, that they do every day take 30 to 60 seconds, eliminating that 30 minutes, getting all the information right to the ambulance companies and an ambulance within an average of 2 minutes. Doing all that transactionally with no phone calls needed. What that also allows for is, from a data repository perspective, to be able to analyze not only your needs in your system, where some of your service level gaps is, and that's where working with the Sadaho team is going to be fantastic as we work through this project. The way this is designed is really, as I had mentioned, an ecosystem. The way we do this is we're going to work with your healthcare systems. Like I'll mention Sanford, we're working through their IT security review. Mobridge is going to be our first go live here in the next few days. Avera is working through some of the processes they're switching through, but we're connecting right directly to their EHR systems in Epic, Cerner, whatever's needed. And we're going to connect right directly to the ambulance company's dispatch software, which will allow somebody to push a simple button, do a systematic ordering that could do anything from any type of ambulance ordering. Now, our product can expand and do ride share, can do air medical ordering, all of that, but it's a systematic ordering process, making sure you get the right resource at the right time for the patient. From that, because of CMS rules and regulations and some of your insurance payers require certain forms, we embed those forms directly into our system, and then that allows for electronic signage. We know who's there, and we can abide by CMS rules. We give automatic notifications back to the hospital system when an ambulance is coming, en route, accepted, even when they're transporting, so they can clean the bed to make sure it's ready for the next patient, helping with that throughput and reducing length of stay. All the way through for being able to manage performance, dashboards, data elements, and then even doing invoicing processes we walk through. The way we do this is that we are that middleware. What we do is we basically connect all those different access points into one single repository, and we make a seamless process to where we connect any type of system, which you'll see on the left-hand part of your screen, that can do ambulance, again, ambulance transport, wheelchair, ride share, Uber, and Lyft. We can do mobile integrated healthcare through our system, hospital to home, especially with that recent expansion through 2030 from the federal government. And the way we do that is through what's called Ride Logic. It's really a systematic way in which we work, that we have a customizable questionnaire that makes sure it's tailored for you and your system. It's not just a one-size-fits-all. We know our urban and tertiary areas are two totally different beasts, and within that, you have to be able to customize it. Embedding all those payer forms that meet, again, those CMS rules, electronically signed, having the right information. Determining the level of servicing, matching it to the right vendors, right, and making sure you get in the right markets, right rules, right people at the right time, and also speed to action to be able to get the patient moved to the timely care that they need. Real-time vendor updates, comprehensive validation rules, all the way through our easy integration within different EHRs that only take a couple hours to do in configuration and not some large IT project. Getting a little transactional, just to kind of give you a little flair of the product, what we do is we embed that easy button. We hit that easy button, 30 to 60 seconds is all the information we need from a caregiver. It'll collate that information, generate those forms based on CMS and OIG rules, goes through our Ride Logic, determines the right resource, goes out to the vendors. Once we get that accepted, we can watch them by GPS if we're connected to them, get all those data, knowing when they're en route, on scene. From that, then you get all the visibility, transactional updates, and have that data repository. The last piece that I'll say here before I actually show you the product in its totality is that the data that you can get is full dashboards. So from a Sadaho, you can see every transport that has been moved across the state in one repository. You can separate that down by facility, by department, down to the floor. You can put this into a data repository such as a Power BI and be able to slice and dice your data to understand and help you identify service level gaps and see in real time both what's going on in your system and where those gaps may lie. With that, I'm going to pause real quick and see if I can get, let's see here. Okay, perfect. Now what I'd like to do is I'd like to share with you what a booking looks like. As I mentioned before, if you're thinking of a floor nurse, a case manager who's got a lot of work to do, they're taking 30, 45 minutes to do this work. All that we have to do for Bride Central, we've embedded one easy button directly onto what's called their storyboard, or where they work every day from the patient. When they do, they just hit the button and launch it, and it goes right into our system. And we pull all that demographic information, things that they have to call, fax, send paper over. We pull that directly out of the EHR. In that, they could do a simple booking. Let's say it's a cardiac patient going from one facility to the next. They could say the patient's ready now. They need an ambulance. I will just put in a contact number in case somebody wants to get notified what's going on. Higher level of care, patient's bed confined. They're going to a cardiac cath. Say they're going for surgery. They have a cardiac monitor in place. And we'll just be very simple. A little bit of payer information that they'll fill in. We'll use it just as a test for a second. And from that, from the last booking when it says not a psych patient, we'll then, oops, I missed the department. From that, all they have to do is then hit save. And in that save, it goes to that Ride Logic. That's all it takes to do a booking. From that, we know the level of service. We know who the vendors are. We're already reaching out to the ambulance companies. You can see it's out being offered to the vendors. You can also see all the forms are being generated, and you can see every bit of the timestamps that are going on with the patient. All with what used to take 30, 45 minutes was done in seconds. Now the ambulance companies, so all these dispatch centers that you have, they'll get a ping and it'll just say, hey, look, we have this specific call that has come in. All they have to do is accept or decline it, or say they can do it at a specific time. Once they hit accept, the hospital gets notified directly when the ambulance company is going to pick up. The other nice part that is a challenge that we have worked to solve for the hospital systems and the caregivers on the floor is the fact that they have no transparency in real time. So if the patient asks and says, hey, what's going on? When's the ambulance going to get here? Caregiver may not know. They may be busy. Nice thing is they can see from the floor anything that progresses. So let's say that unit goes en route. The caregiver right at the floor could look, say they're en route, and their promised pickup time is X time that we pick up by Google. All of this is done in one location. That used to be phone calls back and forth, a lot of frustration. We have solved that. The last piece I want to show you all today, because I want to just understand the power of what this system does, is when we started with the Sadaho group, this was about care and making sure we looked at helping the EMS agencies, helping understand the health system, easing the burden on the caregivers, but getting a data repository to be able to identify service level gaps. What we've done, and we have a specific system in Cleveland that covers about 4 million patients in their whole 17 hospital system through the Cleveland area. They've embedded Ride Central in, and every day they run about 300 calls through our system, transports. In that, they allow us to show their system and their data repository, and you can see in real time right here everything that's being out offered, what's in progress. You can even see ETAs, GPS locations updated. So if you think about what we're trying to do for the state of South Dakota, and once we get all the health systems on board, once we get the ambulance companies, you'll have this repository and the ability to see all your data, what's going on. People are able to support each other, and then you're able to systematically grow, set funding, set policy from that. And with that, I would be willing to take any questions.
Okay, I think we'll hold questions till after the next bill. And we'll get to the bill, and then committee, if you have any questions for Todd or for Tim, we can go ahead. I do have a couple, so thank you. So with that, we will move to, I gotta get my system backed up here. We will move on to Senate Bill 233, prohibit the assessment of certain administrative fees or penalties related to the provision of care by an out-of-network provider. Do we have any proponent testimony?
Mr. Chair, members of the committee, Senator Sidney Davis, District 17. So the bill before you, Senate Bill 233, is a simple bill that is necessary due to recent payer actions that are related to the federal No Surprises Act. And you'll recall that the No Surprises Act was implemented in 2022 to protect patients from receiving surprise medical bills by banning the practice of balance billing for certain medical care from out-of-network providers that were working at in-network facilities. So
Excuse me, there's an amendment.
Sorry.
Did you want to move your amendment?
I do. Thank you so much, Mr. Chair.
Yep, okay, so
I'd
we
ask
have
the committee to
amendment 233A. Would someone like to move that, please? Senator Perry moves 233A, seconded by Senator Smith. All those in favor say aye. Aye. Opposed, nay. Thank you. Please present 233A as amended.
Thank you, Mr. Chair. Thank you, committee members. I appreciate that. So in response, certain payers have begun or announced their intent to begin applying a 10% penalty on payments to providers in circumstances like I just explained. A patient receives medical care from an out-of-network provider like a doctor, and they're at an in-network facility with their insurance provider. So the passage of this bill would prohibit that 10% penalty. In essence, the passage of this bill will not change anything. It is reactive to the actions of the insurance payer. This is in order to just maintain what we currently have now. Failure to pass this bill will lead to those changes, though, in my opinion, not positive ones. So it will affect patient access to independent providers by forcing health systems to work exclusively with their own employed providers, and will increase pressure on these independent providers to either accept the unfair contract from the insurance payer or become a hospital employee in order to continue to treat their patients. And so in this committee, we have discussed at great length the challenges our state has when it comes to access to care. So why would we allow a health insurance company to implement policies that further restrict patient access? I also just wanted to add, the reason for the amendment is that after a consultation with the Medical Association, we decided that we wanted to add some technical language in there to further clarify the bill's intent, to maintain the environment that was created by the No Surprises Act. And so with that, Mr. Chair, I'd ask the committee to please support Senate Bill 233, and I'll stand by for questions. Thank you.
Thank you. Do we have any other proponent testimony? Good morning.
Good morning, Mr. Chairman, members of the committee. Bill Van Camp. I'm an attorney from Pierre and a registered lobbyist for the South Dakota State Medical Association. What we've seen is insurance carriers across the country rolling out a 10% penalty on hospitals when they are, as described by the sponsor of the bill, when they're using out-of-network physicians in their care in network facilities. The practical reality of that is some specialists are largely independent in South Dakota, and we've had a successful independent practice set up in South Dakota, especially in our rural areas where there aren't necessarily the volume of patients to allow for hospitals and clinics in rural settings to add, people in certain subspecialties. And so those have largely, in many instances, remained as independent practices. Now, this penalty will have to be pushed down on the provider. It's assessed against the hospital, but it forces the hospital to consider financially who they're going to hire to provide these services, or allow to provide these services, I should say, in their facilities around the state. This necessarily has to limit access for independent practice physicians, and it does hurt rural access. The No Surprises Act protected consumers from surprise medical bills when out-of-network care is provided at in-network hospitals. That was spoken to by the Prime. That bill was passed in 2020 under the Trump administration, but went into effect in 2022. Now, it's my understanding that the genesis for this action of certain carriers, insurance carriers around the country, has been that they've had problems with the independent dispute resolution provision of the No Surprises Act, and that has caused to expenses, I think, at the carrier level in handling those issues around the country. Well, the solution to that isn't a South Dakota specific issue where you can simply impose a 10% penalty on healthcare facilities in the state. It's to address it at a federal level. The most recent data I received from my client is that over 60% of those IDR complaints have been in only 4 states, not South Dakota. So what they're trying to do is recoup a cost because they're honestly dissatisfied with the outcome of the No Surprises Act and how it's affecting their bottom line. We want things to remain as they are, and they can address this in another means. But to come to South Dakota because you're upset with how a federal act is being implemented around the country is we think, misplaced. You're going to hear from some self-insurance pools that this is going to increase their costs as well. Well, again, that's due to what they're being told is the impact of the No Surprises Act, not because of what we're doing here in South Dakota as we provide care at a specially provider as a specialty physician who's an independent practice. So those complaints are centered on the fact that insurance costs have been going up over the last 5 years significantly, and B, that federal subsidies under the Affordable Care Act are being cut, and that's going to impact these plans as well. For these reasons, amongst others, we think 233 is a good proactive measure. It protects independent practice in South Dakota. It protects patient access, and for that reason, we ask you to support it as amended. Thank you.
Thank you. Do we have any other proponent testimony? Good morning.
I am Dr. Alyssa Green. I am an independent anesthesiologist practicing here in South Dakota. I am board certified in anesthesiology with subspecialty certifications in cardiothoracic anesthesia. Every day I have the privilege and responsibility of protecting and saving the lives of South Dakotans in the operating room, on the labor and delivery wards, in the emergency department, and critical care settings. I appreciate the opportunity to speak to you in strong support of Senate Bill 233. This bill is important because it protects patients and those physicians who care for them by prohibiting health insurance from penalizing hospitals or providers simply because they are not in a carrier's network. In the hospital, there are a few lines of service in which patients rarely, if ever, have the opportunity to choose their own provider. Anesthesiology is one of those unique services. When a patient arrives for surgery or emergently for trauma or childbirth, they trust that a high-quality physician is there at that facility when that will be present to keep them safe, but they don't have a choice in who they see. Hospitals must also ensure that there is anesthesia coverage 24 hours a day, 7 days a week, nights, weekends, holidays. And this obligation exists whether or not an insurer chooses to contract with the physician that provides that care at that hospital. Health insurers nationwide are currently implementing penalties that punish hospitals for care that is provided by an out-of-network provider. Senate Bill 233 helps to protect the intent of the No Surprises Act. Congress passed this act to protect patients from unexpected medical bills, and also it created a fair, independent resolution process when insurers and providers cannot agree on payments. Evidence from these dispute resolution processes have consistently shown that insurers are often underpaying providers for care. Yet, instead of adjusting reimbursement, some insurers are choosing to pursue policies that assess fees or penalties to the hospital with whom these out-of-network providers work. These penalties are punitive. They go to the insurance provider and do not go towards improving the cost or quality of care to the patient. These fees or penalties put pressure on the hospital and providers to accept contracts that are not sustainable for independent practice. Senate Bill 233 ensures that contract negotiations continue to happen in good faith and not under pressure of penalties. When insurers penalize hospitals or physicians for being out-network, the burden does not fall on insurers. It falls on the patients and their access to care. Forcing physicians into unfavorable contracts, whether by insurance provider or pressure via the hospital, does not create independent and high-quality practices that are sustainable. Our practice has historically been able to attract high-quality South Dakotans that want to come back and care for patients here. But the decreasing reimbursement has made this increasingly difficult to do so, and preserving good faith negotiations with insurance providers is paramount. If we and other independent groups in South Dakota are not able to attract high-quality candidates, we will fail to provide the quality and quantity of services that this state currently provides. The ability of health carriers to impose fees or penalties due to the provision of care of an out-network provider has the potential to decrease the access to care and quality of care that patients in South Dakota. The bottom line is that Senate Bill 233 is about putting South Dakota's patients first. Senate Bill protects timely access to care that patients need. It ensures continued high-quality medical services are available and preserves fair health care markets and helps prevent cost escalation driven by unstable provider coverage. As an anesthesiologist, my first responsibility is the safety of patients. Senate Bill 233 supports that mission by ensuring access to care is not compromised by insurance contracting practices. I respectfully ask you to support Senate Bill 233. Thank you for your time and consideration.
Okay, thank you. Do we have any other proponent testimony? Good morning.
Good morning for the third time, Mr. Chair. Tim Rave, representing Sadaho. Mr. Chair, I rise in support of Senate Bill 233 as amended. I think, we're talking about participating and non-participating providers, and that gets a little confusing. It's confusing for me, and I supposedly am in this world. I think a good example, it's close but not perfect, is if you're a Verizon customer, and I'm not picking on either of these companies, if you're a Verizon customer and you call the T-Mobile customer, and you don't notify Verizon that you're calling T-Mobile, you're out of network, you get penalized for that. It's a pretty close analogy to what we're talking about today. And I think if you just think about hospitals, this is from the hospital perspective. And the things that my members and I have been talking about since this has bubbled to the surface is, how in the world is a facility supposed to keep track of, there's no mandate in here that says the provider who jumps out of network has to notify us, and we get penalized for that? I really am trying to stretch to see the logic in that. And so I would give you an example. I think you'll hear from some of the opponents that, well, it's easy, you just ask, Dr. Jensen at the beginning of the year when you have a relationship agreement with them, are you in network? Okay. We don't do that now, but you could. And so you fast forward 5 months later, Dr. Jensen says, I'm not going to be in their network anymore. Nothing in this bill says Dr. Jensen has to tell us. Dr. Jensen keeps practicing at one of our facilities. We get penalized for that. He doesn't have to tell us that he jumped out of network. We're not calling him every day saying, are you still in network, Dr. Jensen? So, for us to get penalized in that scenario, it just doesn't seem logical to me. I would end with this. I think many of you probably have heard, or will hear certainly, that this is going to exponentially increase insurance costs. If this bill passes, nothing changes from the status quo today. So if I was sitting in those chairs, I would ask the question, why are insurance costs going to skyrocket if this bill passes? Because it's exactly the practice we do today. With that, I'd stand down, Mr. Chair, stand by for questions, and appreciate your support of the bill. Thank you.
Thank you, and thank you for upgrading my degree. Appreciate that. Any other proponent testimony?
Good morning, Mr. Chairman. This is Christine Papina. I'm for the bill. I am the Vice President of Value-Based Care and Employee Health Plan Administration for Monument Health. I am representing myself on this bill at this time. I negotiate contracts on behalf of the hospital with the payer. For our employee plan, I negotiate on behalf of our employee plan for payer networks. And I have a history of negotiating contracts for national payers and for hospital-owned payers or small PPO networks. So I've seen kind of all sides of this issue, I would say. From a hospital perspective, we do contract with, most of us, contract with the providers who perform services within our hospital that are exclusive to our hospital. Those contracts sometimes are very old. We don't revisit them on an annual basis, much the same way you would with a payer. They're not required to tell us that they're in network or not network. We're not a party to their contract with the payer. The payer contracts also prohibit us from being a party to those or contracting on behalf of those independent providers. So that relationship is held exclusively between the provider and the payer. So penalizing the hospital doesn't, I agree, necessarily make sense. We're not a party to that relationship. We have no influence over that relationship. We do ask our hospital-based providers or providers who perform services within our hospital to also have contracts with payers and to negotiate a fair contract with that payer, which essentially means the payer can't be unreasonable and the provider shouldn't be unreasonable. And if that situation happens, they can come to us and say, I just can't contract because these are the reasons. Providers tend to go out of network not only because of pay rates, but there are a number of other issues that a provider would go out of network, whether it's unfair policies, undue burden on that provider, inconsistent or unreasonable medical practice requirements, denials, incorrect payments. There's just a variety of issues that can happen between that provider and payer. So I agree that I'm not certain I understand how this will increase costs for an employer group, because essentially the No Surprises Act does resolve that from an employer perspective and a patient perspective. To put the burden of forcing a contract on an independent provider with a payer who may or may not be unreasonable is not fair to the hospital and will create access issues to the extent that we can in elective surgeries, things like that. We don't have control or can't refuse a patient coming into the ED, which means if we have out-of-network providers who are performing ED services, do we tell those doctors they can't see those patients? How do we resolve for that patient? And that may lead to the patient not really getting the care or the quality of care that they deserve by coming to our hospital. To place that burden on the hospital from a discounting perspective from their already discounted services through that agreement with the payer is also unreasonable. Many times those payers have already many times those payers have already gotten to a point that is maybe unsustainable for the hospital already from a payment perspective through either the rates that they're imposing or the policies that they've applied. There's just any number of reasons, and that relationship between the hospital and the payer should not be penalized for other relationships that they have with their other network providers. I think I'm going to end with that I am supporting Senate Bill 233 because essentially it's a complex problem. You shouldn't take a hammer to resolve something that really requires finesse and partnership.
Thank you. Do we have any other proponent testimony? Good morning.
Good morning, Mr. Chair, members of the committee. I'm Kim Malsom-Ryson with Avera. I am here today to support Senate Bill 233, and I would just associate myself with the comments that you just heard about the difficulty of participating providers, in this case maybe a hospital, getting involved in contract negotiations between non-participating providers that provide services in our facilities and independent health plans. It's just a very non-tenable solution that even if these penalties were assessed, are not going to be able to address the core issue, which is part of the IDR process you heard at the federal level. It will not decrease health costs because we just don't have the ability to get to the solutions that this is trying to seek. So with that, we would support Senate Bill 233 to keep the status quo so that those outside discussions can continue to happen as they should between those specific providers and those health plans. Thank you.
Thank you. Do we have any other proponent testimony? We have none online, so with that, we'd move to opponent testimony. Do we have any opponent testimony? Good morning.
Good morning, committee members. Melissa Clayman, I am with Wellmark Blue Cross and Blue Shield, and I do rise today in opposition of Senate Bill 233. I want to begin my testimony today acknowledging that we all share a commitment to ensuring that South Dakotans can access the care they need when and where they need it, but access depends on stable insurance markets, affordable premiums, and predictable provider networks. I've been in the insurance world for over 20 years, and I've seen the fluctuations and witnessed what us 3 domestic carriers in South Dakota have witnessed. Over the past decade, federal and state regulations have added new mandates and administrative costs which flow directly into premiums. Health insurance is now one of the most highly regulated products in the economy. While regulation protects consumers, each new requirement does increase costs for employers and families, especially businesses in our rural communities. I do want to note something particularly ironic as we talk about networks. A decade ago, the legislature was asked to mandate that insurers must accept any willing provider into their networks, patient choice and access to care. Now here we are a decade later, and providers are seeking legislation that makes it easier for them to be out of network in the name of patient access. I've heard the discussion today. Insurance companies are the villain. Insurance companies make unreasonable demands. We throw the hammer down, and we're viewed as the main driver as rising premiums. But I remind you that we operate in a system where insurance companies don't set prices. Wellmark's role is to finance healthcare, negotiate contracts, maintain stable networks, and manage costs so coverage remains affordable. A key part of maintaining access is private contracting between insurers and hospitals. These contracts set prices, quality expectations, and network standards, to name a few. Hospitals, not insurers, choose which physicians practice in their facilities. Insurers are simply asking hospitals to ensure that those providers that are operating in their hospitals have some skin in the game and being in the network to keep costs predictable. Senate Bill 233 weakens our ability to negotiate with hospitals in the spirit of keeping specialty providers in network. So how did we get here today? Why is this bill being proposed about contracts between hospitals and insurance companies? You've heard from the proponents of this bill that it is due to the No Surprises Act and the independent dispute resolution process. The No Surprises Act has the best intentions, and we all can agree. Didn't want to put consumers in the middle and have them receive surprise bills. This is when, I will remind you, this is in emergency situations, air ambulance situations, or when a consumer has no choice about the provider they're seeing. Across the country, and this is across the country, and it is happening in South Dakota, and it is happening in Iowa, the two states that we operate in. This isn't the boogeyman. We are seeing that the federal dispute resolution was put in place under the No Surprises Act to seek rates far above market norms. By late 2024, some awards were up to 930% of the qualifying payment amount. So a health insurance company was trying to find ways to mitigate risks for our premium payers, mitigate risks for our large employers. Senate Bill 233 makes it harder for health plans to discourage avoidable higher out-of-pocket network care. I've seen the handouts, I've heard the testimony. Again, we're the bad guy, and it's about our bottom line. But I challenge to ask you a question. Are rising premiums really the result of our unchecked insurer profits? Insurance companies are subject to strict oversight, and our profits are capped by law. The individuals who follow me today are going to tell you that large employers or self-funded groups are going to bear 100% of that cost. That has nothing to do with Wellmark's bottom line. We are seeing awards on average at 450% higher than insurance's in-network rate. That has to be paid somehow. When we see that, that's going to be reflected in premiums to individuals and families. Your small businesses. I will say it again, access to care is protected by strong, stable insurance markets, predictable regulations, transparency, and in-network providers. Policies that weaken these foundations risk increasing costs and reducing access to affordable health care. I want to be clear. Wellmark is not getting up today to defend what is happening in contract negotiations or the 10% penalty you heard about. Wellmark is getting up today for the precedents that the legislature is getting involved in private contract negotiations and with sophisticated entities. So as you consider, I also heard if this bill passes, nothing changes. So if nothing changes, why are we here today? As you consider Senate Bill 233, remember that contract negotiations between hospitals and insurers are happening privately and thoughtfully. and that this bill is being advanced by outside individuals outside of that process. A yes vote, unfortunately, inserts the legislature into private contracting and removes the ability for insurers and hospitals to resolve these issues collaboratively. A no vote preserves stability, protects affordability, and ensures South Dakotans can continue to have access to care. Thank you, and I'll stand by for questions.
Okay, thank you. Before we go to more opponent testimony, we did have one proponent that stepped out of the room just briefly before I quickly moved to opponent. So if you could.
Sorry about that. Thank you, Mr. Chair. Allie Dawes on behalf of Sanford Health. We would just ask for your support and associate our comments with the previous proponents of the bill for Senate Bill 233. Just wanted to be on the record for support. Thank you.
Okay, thank you for the brief comment. Do we have any other opponent testimony to Senate Bill 233? Good morning.
Good morning, Mr. Chair, members of the committee. My name is Carl Adam, and I serve as the president and CEO of the South Dakota Bankers Association, representing over 70 members and doing business in South Dakota, and I'm also a registered lobbyist. Many of you may wonder why the Bankers Association is appearing before the committee in opposition to Senate Bill 233. Well, our association sponsors a health insurance plan that covers more than 3,000 bankers and their families across the state. I want to underscore that our insured members have been pleased with the work done by our health insurance carrier, as well as the great service by South Dakota healthcare providers. However, for us, this issue is not theoretical. It directly impacts the affordability of health insurance for working South Dakota families. Senate Bill 233 inserts the legislature into what is fundamentally a private contractual dispute between sophisticated healthcare providers and health insurance carriers. These parties negotiate network participation agreements that establish reimbursement rates, administrative procedures, and financial terms. Those agreements are voluntary and the product of an arm's length negotiation. This bill is premised on the idea that out-of-network providers should not be subject to administrative consequences tied to out-of-network billing. But when provider chooses not to participate in network, that provider also chooses not to accept the negotiated, agreed-upon reimbursement rate. Allowing out-of-network providers to bill beyond contractual rates without meaningful cost controls undermines the entire purpose of the contracting network. Health insurance networks exist to create predictable pricing, to control healthcare costs, reward providers who have agreed to negotiated rates, and to deliver affordable premiums to employers and families. If out-of-network providers are effectively insulated from contractual consequences while still being able to demand higher reimbursement, the negotiation balance shifts dramatically. Carriers will have diminished leverage to secure reasonable rates. The predictable result is higher claims costs. And higher claims costs do not stay with the carrier. They are passed directly on to small employers, employees and their families, retirees on fixed income, individuals purchasing coverage on their own. For our 3,000 plus covered lives, even modest increases in provider reimbursement can translate to significant premium increases. Over time, that makes coverage less affordable and pushes health insurance far out of reach for working South Dakotans. This bill also sets a concerning precedent that you heard from Ms. Klayman here just a moment ago. It signals that when private parties negotiate contracts, the legislature may adjust the economic terms if one side becomes dissatisfied. That injects uncertainty into the markets that rely on stability and predictability. Importantly, nothing prevents providers from joining a network, negotiating higher reimbursement rates, declining participation altogether. Those are business decisions, but those business decisions should not be subsidized by the statutory intervention that ultimately shifts costs to insured families. The healthcare system today is already under cost pressure. Employers are struggling with double-digit premium increases nationwide. Adding statutory limitations that weaken cost containment tools will only accelerate this process. We respectfully submit that this matter best be resolved by the contracting parties, sophisticated healthcare carriers, and sophisticated provider systems, rather than through a legislative mandate. For these reasons, the South Dakota Bankers Association respectfully asks this committee to oppose Senate 233 as amended. Thank you very much, and I'll stand by for any questions.
Okay, thank you. Do we have any other opponent testimony? Good morning.
Good morning, Mr. Chair, members of the Senate Health and Human Services Committee. I need to apologize for my voice this morning. I'm sorry, I'm a victim of the Capitol crud. Oh, we'll try to get through this, okay? My name is Darla Pullman Rogers, and I'm a registered lobbyist for NAFA of South Dakota, which is a state organization comprised of life and health insurance agents. And we rise in opposition to Senate Bill 233. You have heard some excellent testimony in opposition to this bill, with which we concur. But here are the points that I would like to emphasize for you today. This is a larger problem than just South Dakota. You have heard about the No Surprises Act and the Independent Dispute Resolution, or the IDR process that is in place, is broken. There is no quick fix for this situation. South Dakotans who are all, and what has, as a result of this broken process, this has created a new affordability crisis for South Dakotans and even for Americans across the country. Senate Bill 233, if adopted, would actually increase or move the affordability crisis in the wrong direction. It would make coverage more unaffordable. Health plans are doing everything in their power to shield South Dakotans from the high and rising costs of medical care, including implementing policies such as those at issue in Senate Bill 233 in response to growing issues with the IDR process. Taking away these important tools will only further impede health plans' ability to improve affordability. As has been said, let's focus for a moment upon what efforts health plans are taking to improve affordability. Health plans are attempting to encourage in-network participation. Strong in-net participation leads to lower out-of-pocket costs. Senate Bill 233 would impede the ability of health plans to prevent providers from remaining out of network in order to charge higher reimbursement rates. And as has been pointed out before, let's look at the parties involved in this process. Health insurers contract with hospitals. These are private contractual arrangements and negotiations between two sophisticated entities. And that contractual process is important to help cost predictability for insureds and to protect insureds from avoidable out-of-network charges. I want to bring this back to my agents, if I could. Let's focus here on the overriding goal. The overriding goal is affordability of health insurance for South Dakotans. It's not to interfere in private contractual relationships and negotiations. It's not to pick winners and losers in private contractual negotiations. It's not to incentivize and protect some out-of-network providers at the expense of insurance premiums for insureds. The goal is to help South Dakotans find affordable health insurance. So let's bring it home to my life insurance agents. They're the ones that are out in the field. They are sitting at the table across from South Dakotans who are seeking affordable health insurance plans. These are your constituents. My agents have the daunting job of telling South Dakotans your health insurance premiums are rising. The bottom line is that South Dakotans are struggling to afford health insurance premiums. Let me share with you a message from one of my agents, and this is a quote. This is in regard to Senate Bill 233. I'm about worn out trying to help people figure out how to manage their rising health insurance premiums. And boom, a bill like Senate Bill 233 comes along that will blow the people of South Dakota's premiums up even more. Please don't give the special interests a blank check to take what they want from the premium paying people of South Dakota. We would urge you to protect the premium paying people of South Dakota. Please defeat Senate Bill 233. Thank you.
Okay, thank you. Do we have any other opponent testimony? Good morning.
Good morning, Mr. Chair, committee members. I'm Blake Severin with the Independent Insurance Agents of South Dakota. And similar to Ms. Rogers, my members are the ones that are out there having these conversations with their customers. Our members make up about 90% of the independent insurance agencies in the state, and this would be a huge problem for them. To keep premiums stable, as the other great testimony before me has mentioned, there needs to be stability, and this is not just health insurance only. Your home insurance, your auto insurance, those carriers rely on tools to manage what they pay out in claims. And when those tools go away, as this bill seeks to accomplish, it shows up in the premiums that all South Dakotans pay. And in a time of uncertainty about future healthcare premiums, I agree with the other opposition that it's not the time for legislation that gets into these contract negotiations. So for these reasons and the ones mentioned before, we urge you to vote no on SB 233. Thank you.
Okay, thank you. Do we have any other opponent testimony? Good morning.
Good morning, Mr. Chair, members of the committee. My name is Sarah Rankin, and I'm the Executive Director of the South Dakota Municipal League, and I'm here today on behalf of our 309 municipal members from across our great state. The South Dakota Municipal League relies on insurance providers to negotiate competitive provider contracts and reimbursement rates that keep health coverage stable and affordable for the municipalities that we represent. Our member cities and towns operate on tight budgets, and predictable premium costs are critical in that process. Any policy change that limits the ability of carriers to manage networks or negotiate rates ultimately shifts the costs back to local governments and the citizens that work for them, many of which who are your constituents. We respectfully ask that you consider the downstream fiscal impact on municipalities as you evaluate this legislation. And with that, we ask for your opposition on SB 233. Thank you.
Thank you. Do we have any other opponent testimony? We have none online, so we'll be just in the room here. So, good morning.
Good morning, Chair, members of the committee. My name is Brenda Foreman. I'm Executive Director and Registered Lobbyist for South Dakota Association of Cooperatives, and we do rise in opposition to Senate Bill 233. Visits with members have raised concerns, and those have been noted by the prior testifiers, so I'm not going to go back into detail, but they have very well shared our concerns. So with that, we see the passage of Senate Bill 233 as preventing our healthcare providers from taking steps to prevent and protect the programs and benefits that we as businesses do provide to our employees, employers, and their families in both small and large communities. So with that, we would respectfully ask for your resistance to the passage of Senate Bill 233. Thank you.
Thank you. Do we have any other opponent testimony? Is there any other opponent testimony in the room? And we have none online, so we'll offer time for rebuttal.
Thank you, Mr. Chair. Senator Sidney Davis, District 17. So I just want to bring us back a little bit. We heard a lot about these are private contractual relationships. But then why are we penalizing hospitals because the insurance company and the provider can't there's a lot of reasons why an insurance provider and the doctor or clinician, whoever it may be, maybe there's a lot of reasons why they're not in network. And we heard a little bit of that from in proponent testimony. I want to clarify something too. This doesn't apply to ERISA plans, which is like an employer sponsored plan. This is something your employer is providing to employees. This does not apply to that. Employers would still be able to dictate those terms for their plans. And insurance premiums are going up right now. This penalty doesn't go into effect until July. So this bill would just keep would just keep the status quo as it is right now. Your insurance premiums are going up without this even in effect yet. So the opponents want to talk about this 10% penalty being used as a cost containment tool. I would consider that more, or a negotiation tool. I would consider it more of as a tool to bully hospitals and providers into joining their network. And again, why don't they want to be a part of the network? Why doesn't the insurance provider go to the providers themselves and say, hey, Dr. Jensen, why don't you want to be a part of our network? Well, Dr. Jensen more than likely is going to say, well, you only want to reimburse me for 30 cents on the dollar for the care I'm providing. That's one example. There are a variety of other examples why they might not be participating in the network. Or maybe they don't want to be tied to, if you're in one network, you can't be a part of another network. There's a lot of consequences to that. And so there's a reason why people want to be independent. So I just want to leave the committee with those thoughts and ask you to support the bill and remind you again, these are private contractual relationships between a insurance provider and the doctor, clinician, whoever it might be. Then why are we penalizing hospitals? Thank you.
Okay, thank you. With that, I'd open it up to committee questions. I have one, and I don't know who could answer this. So anybody that thinks they can. How many providers are we actually talking about that might be in this position right now? Any idea? Is it 50 doctors? Is it 100? Is it 1,000? No idea? Okay, thank you. Guess not. Any other questions from the committee? Senator Perry.
Thank you, Mr. Chair. I think this would be a question for Darla, even though you're having trouble speaking. Sorry to persecute you.
And go ahead and introduce yourself again, too, please.
Mr. Chair, Darla Pullman Rogers, representing NAPA of South Dakota.
Mr. Chair, basically, the affordability statement that was made was really important, but the premium paying people was another thing that was said. I'm just wondering, how much is this affecting the premium payers?
Mr. Chair, I believe it's directly affecting the premium payers when you impede the ability of the health insurance carriers to negotiate contracts. I think that has to be made up somewhere, and it's going to be your premium paying people of South Dakota that are bearing those costs.
Senator Smith.
Not exactly sure who wants to step up and answer this question, but I'm sure somebody will, so thank you. I want to be walked through a situation where I come in and have surgery at a hospital and I have an in-network anesthesiologist. I get my bill. I go to the same hospital on a Saturday. I have an out-of-network anesthesiologist. I get my bill. What's that look like? because I know they're different. So tell me what that looks like and who can help me with that.
Melissa.
Introduce yourself again, please.
Melissa
Thank
Clayman, Wellmark Blue Cross and Blue Shield. So what happens for the consumer in this process due to the No Surprises Act? So first we'll start off, you go to an in-network provider, you go to a facility, and your anesthesiologist, for example, is an in-network provider. Consumer's going to receive their bill based on their copay, their coinsurance as it exists. So you won't see that. Now, you go to have surgery in facility, out of network anesthesiologist, and I'm sorry, I don't mean to use anesthesiologist, it's the easiest that comes to mind. What is going to happen now is consumers not going to see any difference due to the No Surprises Act, okay? The No Surprises Act was put into place to make certain consumers were not into this process. What is happening different today is because of the independent dispute resolution, insurance company, and I'm going to throw out figures, and these are not real figures. Insurance company is going to offer to pay that anesthesiologist $1,000. So it's $1,000. Anesthesiologist says, I don't agree with that. I billed $10,000. So it goes to an independent dispute resolution process, arbitration. What is happening 80% of the time is now that figure is at $8,000. The anesthesiologist, insurance company says, I'll pay $1,000. Anesthesiologist says, I want $8,000. They are being awarded that $8,000. There is also a fee that goes along with this. It's a $125 fee for everything and an additional $450 fee, plus the legal fees associated with that arbitration. So now, in an in-network facility, or in an that rate, we had offered $1,000. That award to that anesthesiologist is $9,000. That's the difference that we're seeing when you see these at 950%. Does that help answer your question?
Yes, follow up. What's the patient seeing?
The patient, the No Surprises Act, the patient is not going to see it. It is out of the view of the patient. So the patient will see the billed charges, but their coinsurance and their copayment is going to be reliant on whatever their contract is for their insurance.
Thank you. There's somebody else who wants to add something to that?
Yeah, and go ahead and follow up.
Okay. Well,
Yes, go ahead and introduce yourself again, please.
Thank you. Yes, Christine Papina, Vice President of Value-Based Care for Monument Health. I can't honestly speak to the things that she said as far as how the claims are paid, but how this is written for the penalty for the hospital is, you had said an in-network anesthesiologist and an out-of-network anesthesiologist. How this is written in South Dakota is that the hospital has fulfilled their contract with the payer and performed an in-network service. Now, whether that provider that performed the service, the anesthesiologist, is in-network or out-of-network, it doesn't matter. The hospital is penalized on every claim. And that's really what we're opposing. Thank you.
Thank you. I think I'm going to call my new professor up. And because you represent a lot of hospitals, can you enlighten me at all about how many providers that we could possibly be looking at that this would happen with?
Thank you, Mr. Chair. As usual, you ask profound questions. And as I didn't jump up because I didn't know the answer. And then it occurred to me, because I'm a little slow. I'm sorry, Tim Rave, Sadaho. Thank you, Mr. Chair. I'm a little slow on the uptake. Well, it occurred to me, this is exactly what we're talking about. This is a simple bill that clarifies what we do today, continue to do what we do today. And the point is, Mr. Chairman, we don't know. That's the whole point. As hospitals, we don't know who is in network or out of network on any given day. That's the whole point we're trying to get at. And as the good senator who brought the bill said, Why are we getting penalized, not the provider, not the insurance company, but the hospitals who don't know are getting penalized financially? That is the whole point of the bill. Thank you, Mr. Chairman. Great question.
Thank you. Any other questions from the committee? Okay, seeing none, we'll close testimony and move to committee action and/or discussion. I'm just going to make a quick comment before we get a motion. We've heard about the insurance companies and we've heard about the hospital penalties, but the one thing I didn't hear very much about is how it affects the patient care. Isn't the patient the most important part of all of this? So anyway, that's just my comment, but I'd entertain a motion or some discussion from the committee. Senator Perry.
This would be, excuse me, this would be discussion. I got a note last night, and it's from a large business in our community up in the Aberdeen area, but it's a business that goes all the way along Highway 281 and all along Highway 12. And they said SB 233 is up for consideration tomorrow morning in the Senate Health and Human Services Committee. This bill would materially increase their company's employee health care insurance costs. We would ask you to please vote no on it tomorrow morning in the committee. I'm getting a lot of businesses that are contacting me saying, just say no. I think that they read that article from Nancy Reagan, and they just keep saying, just say no. So at this point, I'm leaning no.
We don't have a bill yet. I mean, we don't have a motion yet, so any other discussion or action?
Mr. Chair.
Senator Grove.
I would make a motion to send this to the 41st day.
Second.
So Senator Grove moves Senate Bill 233A as amended to the 41st day, seconded by Senator Perry. Any discussion on your motion?
Mr. Chair. So I love independent doctors. I worked with one for a number of years. My problem with this is that I feel like we're getting into a custody fight. I feel like there's two entities involved here who have a lot of money and a lot of lawyer power, and I think they'll figure out how it works. And I'm concerned that if we step in and start putting our input into this thing, that we are muddying the water and just playing in a little pool that we shouldn't be in. That's my thought. Thank you.
Thank you. Any other comments? Senator Reed.
Thank you, Mr. Chair. First of all, I want to thank both the opponents and proponents for lively discussion over the last week. This was first of all, tough issue to really get your hands around, how it affects everything. And then there were good points made on both sides about this issue. From the insurer's point of view, are you driving up the cost for the individual? Now, this is also an end around the dispute resolution board. I don't know if we should be doing that yet. If we got that in place, on that side of it. And the other thing is, I got an email earlier, just this morning, from an insurance agent showing an email that they received about a patient's bill. And the person sending the email was like, they're charging $160,000 for this procedure. And this other doctor said, well, that's only about a $40,000 procedure. And that person was convinced they were charged $160,000 because that's what it looked like on the bill. Well, guess what? You read down further, and there was a $140,000, adjustment made. And so you think about how the consumer's thinking about this if they're not quite understanding that, right? And so I also want to say that we got to get to the real number here. I mean, what do these things really cost? And to the points made before, we're getting in the middle of this. And I don't know if that's what we should be doing. And so for that reason, I'm going to support the motion to move it to the 41st day.
Okay. Any other comments from the committee?
Mr. Chair.
Senator Davis.
I'm going to resist the motion, obviously. I think right now insurance companies are meddling. I think they are putting an unfair tactic in place right now. Patients, in my opinion, won't see much of a change because, as we heard from the opponent with a question that was asked, nothing really changes on what they see. What changes is now this is a tactic that's going to be used to bully independent providers into joining a team that they don't currently want to be a part of. That's what's really going to happen. That's what will happen. These penalties don't go into place until July. We're trying to bring this bill to discourage them from doing that. And so if you really love independent providers, if you really like freedom, you really like choice, this preserves that choice and it forces the insurance companies to actually negotiate with the provider instead of bringing in the hospital who has no knowledge of any of this, doesn't know what doctors in and out. They don't know that day to day. They're penalizing somebody in a custody case. They're penalizing the kid for the fact that two parents can't get along. And that's what this bill is trying to prevent. Don't penalize the middleman. Don't penalize the hospital. Make the adults figure it out. So this bill is preventative. I'm going to resist the 41st day motion.
Okay, Senator Perry.
Thank you for those comments, and my comments are really simple. I agree with the senator from Brookings. There were some really good opponents and really good proponents here, and this is the information that was presented was well presented. It's a good concept, but I think premiums are a big factor. And should we be involved with private discussions? Should we be the moderator? Should we do this? And because of that, I'm agreeing with the senator that brought the bill to move this to the 41st day.
Okay, thank you. Any other comments? I'll make one. I'm going to resist the motion also because, we've heard a lot of, and I'll be blunt, heard a lot of scare stories, a lot of scare tactics. But nothing has really been quantifiable here. I don't have any number. I mean, yeah, we're going to raise your insurance rates, but nobody really actually quantified how much that would be, or even if it would really happen with every provider. Maybe Blue Cross Blue Shield would, yes. I have Blue Cross Blue Shield. I may be the independent insurance agents, but I really did not hear anybody say specifically that this is going to be the effect. In law, in these committees, we want to know. I want to know what the effect is. I don't want to. This is a bad word. I don't want to be bullied into thinking that if I vote for this, I'm going to throw everybody's insurance premiums through the roof, when I didn't really hear anything quantifiable evidence that exactly what that would be. So I'm going to resist the motion to the 41st day. So, with no more comments, Senate Bill 233A as amended has been moved to the 41st day by Senator Grove, seconded by Senator Perry. I'll ask the Secretary to call the roll.
Senator Grove.
Aye.
Perry.
Aye.
Reed.
Aye.
Smith.
Aye.
Voigt.
Aye.
Davis.
No.
Jensen.
No.
Mr. Chair, we have 5 yeas and 2 nays.
Okay, thank you. Senate Bill 233A as amended will move to the 41st day. With that, if anybody had any questions about the earlier presentation, I guess I have just one real quick question. It's probably very basic, but I was just going to ask if this is for facility-to-facility transport, not a 911 call. I just want to clarify that.
Yeah, great question, Mr. Chair, and thank again for the opportunity to show the product to everyone. And yes, it's only for inter-facility transfers that are otherwise not scheduled. So it's
Quiet.
again I think the cool thing about this demo that we're talked about today is it's a statewide it's the first time we've done this statewide, I think, anywhere in the United States. Is that correct, Todd? So, it's the first time this repository has been for every service and every hospital across the state to try and facilitate the better movement of patients across the state. So more to come. We're not done with the grant yet, and we're hoping for an extension because people, as a project this large, I think we found 2 years probably wasn't enough. And that's kind of why I wanted to present it to you all today, because at some point it'd be nice to have you nudge some of the services in your area that, hey, I think it's a good thing to join this. We've had really good uptake, but we could have some more improvement in that space. And I think we're really looking forward to not only getting patients, which is the number one priority, to the right facility in a timely fashion, but the data that it's going to provide and say, oh yeah, in this state we had a gap of 400 people that couldn't get transferred in a timely fashion last year. I mean, there's really two benefits from this plan. So just appreciate you guys' indulgence in letting us present it. And we are going to have an open session after the Senate looks like it's pretty short today. You only have a couple bills on the floor. So Todd is going to have the product up and just show it live to legislators. And if one of you would be willing to announce that at the end of session, thank you, Senator Davis. That would be great. And we'll be up in, I think, 4:13 at the end of session. So thank you, Mr. Chair.
Thank you. Senator Smith.
Could you help me, and you probably said this and I missed it, but who administers this for all these different groups in the network? How does that work again? Like, is somebody far away on a cloud administering this and we just pay a fee, or is there somewhere in state that they're...
Mr. Chair, good question, Senator. Yeah, it's a web-based product. You saw it on the web, just like be how anybody would see it in the hospital. So the nurse or the social worker putting that transfer in goes into that platform. It's the Ride Central platform, but it's web-based and it can run from any computer in any hospital, in any ambulance station, et cetera. So, yeah, great question, but that's how it would operate.
And then is it you pay for annual service fee or something like that you'd pay to be a member of that organization?
Mr. Chair, correct. That's exactly right. It's not per call or anything like that. It's a flat fee that we use the grant money to pay Ride Central to implement it. You put a little icon. I'd let Todd get up here. Put a little icon on the computer. You just click it. You go in, log into the system, put it in, pay a flat fee for that. So, did I describe that right, Todd?
Great. And one more, at different levels, could you do I know like within schooling, like you can get a whole district can get something, or you can get just a school would get it at different fees.
I'll let the expert come up, but the answer is you can get different.
So let's say the entire I'm going to pick on Avera because I see Avera right there. Avera system says, yep, we want this, right? And so does Avera pay an entire fee, or does each individual Avera pay for that?
Senator, so in the structure, I'm going to answer that in two different ways, actually. In the structure of the grant, it's all inclusive. Okay, it doesn't matter in this. If we were looking as doing an independent costing, it would be by health system, and then they have two options with that. Number one option is by instance, right, or what we call by booking. So you use it, you pay for it, right? Some of those share that with the transport companies. It's a couple different ways, however they want to handle the financial. The other option is an all-inclusive option. So let's use Avera. Avera has all their health systems. Maybe they don't want to just use it for ground ambulance. Maybe they want to use it for wheelchair, air medical. Maybe they want to connect Uber and Lyft with it, and for those 20-30% of the calls that are going by ambulance could be cost shifted and moved for health savings, smoother and quicker movement of patients. You can actually book Uber and Lyft directly through our platform. So we have all of those. So when you think of, they may have an internal shuttle service. We can put that into it. So if you think of any transport mode that happens from a healthcare perspective and all that Rolodexing, I'll give you one other scenario. I'm a new nurse, so I'm going to role play. I'm a new nurse, Todd. I come in, I've been working in, let's say, Fargo, North Dakota, and I come down here to Sioux Falls. Brand new, first time somebody goes, order a transport. Where do I look? What do I Rolodex? Who do I find? Who am I yelling down the hall for? Is there somebody as a tech? I don't know. Did I call the primary vendor? Did I accidentally call the second? Did I jump someone's contract? Did the contract change? The caregiver on the floor doesn't need to know that, right? They just need to know if they can hit a button, they can answer a few questions, the right resource is going to show up, and it can be at the most cost-effective manner for saving the health system money, but still moving the patients timely.
Senator Reed.
Thank you, Mr. Chair. And I guess this would probably be for, since we're elevating, should we start calling him Dean Rave? But for Mr. Rave. When you're looking at the grant application, have you figured out that there will be long-term savings? Is that something that you're working on with it?
So I would say from our perspective, our goal is to work with SDAHO to be able to get the data to ultimately be able to understand what the service level gaps. That was really our understanding of the initial grant side to this. Part of with Ride Central and what we've seen, I can't tell you here in SDAHO because it's a very focused style grant, moving patients that are in just ambulance only. It doesn't involve wheelchair, it doesn't involve other things, or ride share. So it's very focal. Part of what we've seen in other health systems is what's called payer of last resort. It's when maybe it's self-pay or an insurance company doesn't pay or whatever. That cost shift sometimes goes back to the healthcare system, and then they have to pay for the ambulance ride. All right. What we've seen because of how we're connected with the health systems by the data we get, we see a 50% reduction in that typically. And for the ambulance companies, you see somewhere between $50 per trip and $70 per trip increase in revenue because we're pulling across verifiable insurance. We're getting all those payer forms up front. So all the insurance folks that were in here, it can flow through, it can meet CMS rules. So we've seen a significant cost savings on the health system side, while in turn getting more money into the pockets of the ambulance vendors, trying to help avoid, like we hear about ambulance deserts all the time.
And I guess just a comment, I'm looking at the sustainability, which I think we'll look at every single one of these grants. What's the sustainability?
Yes. Thank you,
Good.
sir.
Good, and thank you for doing a session this afternoon that Senator Davis will be announcing.
Thank you so much.
Okay, thank you.
Appreciate it.
With that, we'll see you this afternoon. I'd entertain a motion to adjourn. Senator Perry moves adjourn, seconded by Senator Reed. All in favor, say aye. Aye. Opposed, nay. Thank you, everybody. We are adjourned.
From choir to debate to theater, SDPB shines a spotlight on South Dakota's talented students through SDHSAA All-State Fine Arts Programming. Good, useful, and full of wonder. SDPB. Every day, SDPB connects South Dakotans with stories that inform, inspire, and bring us together. SDPB, good, useful, and full of wonder. SDPB is your home for fact-based journalism, connecting South Dakotans with news they can trust and stories that matter. Good, useful, and full of wonder. SDPB. From children's programs to in-depth documentaries, SDPB sparks curiosity and lifelong learning in every South Dakotan. SDPB. Good, useful, and full of wonder. SDPB brings South Dakotans together, telling the stories that unite small towns, big ideas, and the people who make our state shine. Good, useful, and full of wonder. SDPB. SDPB shares the voices and experiences of South Dakotans, preserving our stories, our culture, and our sense of place. SDPB, good, useful, and full of wonder. As South Dakota's public media network, SDPB serves everyone with transparency, integrity, and commitment to open access. Good, useful, and full of wonder. SDPB. SDPB helps shape South Dakota's future by educating, informing, and inspiring the next generation of thinkers, leaders, and creators. SDPB. Good, useful, and full of wonder. SDPB serves South Dakota through an interconnected communication system that is on 24/7, 365. The first place for Amber Alerts, public safety announcements, and EAS messages. SDPB keeps public servants and citizens informed. Good, useful, and full of wonder. SDPB. SDPB brings you closer to your government. With gavel-to-gavel coverage of the South Dakota legislature and in-depth reporting from peer. Good, useful, and full of wonder. SDPB. From early learners to lifelong students, SDPB inspires curiosity through trusted educational programs and resources for every stage of life. Good, useful, and full of wonder. SDPB. When South Dakotans need reliable information, SDPB is there providing updates and coverage that keep our communities safe and connected. Good, useful, and full of wonder. SDPB. SDPB celebrates South Dakota's student athletes with live coverage of SDHSAA state championships, sharing the excitement of hometown heroes. SDPB. Good, useful, and full of wonder.
I'll call Senate Local Government Committee to order. I'd like to welcome everyone and greet our internet listeners and watchers now that we're live streaming video. Just a reminder for everybody to make sure they have their cell phones either off or on silence. And I'll ask the secretary to please call the roll.
Senators Nelson. Here. Roll.
Here.
Shanefish.
Here.
Smith.
Here.
Whiff.
Here.
Duhamel.
Here.
Reed.
Here.
Mr. Chair, we do have a quorum.
Thank you, Madam Secretary. We also have the minutes from our previous meeting.
So moved.
We have a motion to approve made by Senator Duhamel, seconded by Senator Nelson. Comments on the motion? All those in favor will say aye.
Aye.
Opposed? The minutes are approved. Okay, so I'd like to remind all the testifiers to sign in. We have a new electronic system. Looks like we've done pretty good because we have the list of folks already. But if you haven't signed up yet, there's an iPad over there, and the pages can help you out if you need some help with that. And with that, I'd like to have the pages come up and tell us a little bit about themselves, their name, where they're from, and what their future plans are.
I am Lee Decker, a junior at Stevens High School, and I plan on going to law school after I graduate.
Thank you.
I'm Esther Burkhalter. I am from Prairie City, South Dakota, and I hope to attend SDSU to get a business degree.
Good for you. Thank you. If you do have any handouts, if anyone has any handouts, please give them to the page to distribute to the committee. So with that, we'll take the bills in order. We have both Senate Bill 236. We also have Senate Bill 237. We may have to go at ease for a little while waiting for Senator Davis, as she's in Taxation Committee and needs to make sure she's available for a vote. So we will start with Senate Bill 236. This is an act to create the County and Township Infrastructure Fund for the accounting, safekeeping, and allocation of unobligated rural access infrastructure fund monies. And I'll ask for proponent testimony. Proponent testimony.
Thank you, Mr. Chair, members of the committee, District 1 State Senator Mike Roll. And before we begin, may I ask the committee to move Amendment A as an apple?
So we have 236A. Entertain a motion.
I will move adoption of that amendment.
Second.
We have a motion made by Senator Whiff, a second made by Senator Duhamel. And any comments on the motion? Seeing none, all in favor will say aye.
Aye.
Opposed? The amendment passes, and you may speak to the bill as amended.
Thank you, Mr. Chair. I appreciate you guys getting that in the proper form. This legislation creates the County and Township Infrastructure Fund to provide for the proper accounting, safekeeping, and allocation of unobliged dollars currently sitting in the Rural Access Infrastructure Fund. At its core, this bill is about stewardship, efficiency, and long-term stability for rural infrastructure funding. And unlike some of my other bills that I have to pitch the whole thing, I got a lot of proponents in this one, so I'm just going to sit back and let them make the case.
Thank you. Further proponent testimony. Proponent testimony.
Thank you.
Mr. Chair, members of the committee, thank you for the opportunity to testify today. My name is Michael Lindgren, registered lobbyist for the South Dakota Association of Towns and Townships. Excited today to bring you SB 236. Before we get into the mechanics of the bill, I'd like to begin with a brief summary, history of the program. Beginning in 2021, the legislature appropriated $3 million to help repair and maintain rural infrastructure projects, including some roads and culverts. These dollars were distributed to counties in proportion of total number of eligible projects. In 2022, the legislature made an additional appropriation of $25 million, spaced out over 3 years, the last of which was appropriated in fiscal year 2025. Since the appropriation of those dollars, we've seen hundreds of projects funded and completed, maintenance projects done, a lot of good with those dollars. But there is a bit of a wrinkle that's come out. Some counties quickly zeroed out their RAFE balances, obligating dollars to projects that had been waiting for funding for years. Other counties with a shorter queue of projects on hold utilized fewer of those dollars. The consequence of that is some of these counties still have a lot of need but no money, whereas other counties were appropriated dollars that they do not have projects ready for. Today, about $5 million in unused RAFE dollars sit in county accounts while other counties wait for new funding. SB 236 is our solution to that problem. Under SB 236, RAFE dollars would be recycled at the end of the appropriation's lifespan. If, for example, an initial $3 million appropriation was spent down to a balance of $100,000 across all counties, SB 236 would allow those $100,000 to be reverted to this intermediary fund before being redistributed using the exact same formula as the original RAFE program. Importantly, this bill also helps mitigate the need for ongoing appropriations to the RAFE program. By better utilizing and structuring funds already available, we reduce pressure on the general fund and limit the need to continually backfill or supplement RAFE with additional state dollars. This is a fiscally responsible approach to maximize existing resources before asking taxpayers for more. Our counties and townships are responsible for maintaining thousands of miles of roads and bridges that serve agriculture, school transportation, emergency services, and local commerce. The Rural Access Infrastructure Fund has been an important tool in assisting those efforts. However, over time, unobligated balances have accumulated, and those dollars not always deployed in the most direct way to meet ongoing needs in the moment. Senate Bill 236 ensures those unobligated RAFE dollars are preserved in a dedicated fund specifically for county and township infrastructure. By creating a clear structure for the management and allocation of these funds, we improve accountability and ensure these resources are used where they are most needed. This legislation supports local government while also respecting the budgeting process and reduces the likelihood of recurring funding requests in future legislative sessions. With that, happy to answer any questions. I'll stand by and appreciate it. Thank you all.
Thank you. For the proponent testimony for Senate Bill 236, proponent testimony. Welcome.
Good morning. My name is Chris Jacobson, and I serve as the Executive Director for South Dakota County Commissioners. And as was mentioned, counties and townships maintain a majority of the culverts and small structures across the state while facing rising costs and limited tax bases. So while this bill ensures obligated rural access funds are directed to local infrastructure where most needed. So we urge your support of 236 as amended.
Thank you. Further proponent testimony. Do you have any more proponent testimony in the room? Seeing none, I think we have an online proponent. Dustin, all right, can you hear me?
I sure can, Mr. Chair.
Great. Go ahead. Introduce yourself, please.
Mr. Chair, members of the committee, Dustin Lyseth, Vice President of the South Dakota Association of Towns and Townships. I'm here today to ask for your support of Senate Bill 236 for this reversion of these funds. I just want to reiterate that RAFE helps maintain township infrastructure for rural growth and development. It drives, township roads drive South Dakota agriculture. Poor culverts can not only affect the township roads, but also the land surrounding them. They can potentially delay planting, harvest, and delivery of commodities. Outdoor recreation also depends on township roads. There's over 1.25 million acres managed by the game fish and parks for hunting and fishing. Public access to these acres often relies on township roads. Emergency services, fire, utility crews have the need for safe access. Flooded roads can delay response times and endanger lives. RAFE helps ensure safe roads and reliable access and is important for the economic growth in rural South Dakota. I am from Hamlin County, and our county has utilized all the funds that were distributed through the RAFE program over the last 4 years, which was just over 500,000. So we've gone a year without funding here now. And we're one of many counties that have the zero balance. And with this reversion, for those counties that haven't utilized them to their full extent, that reversion would greatly help a county such as mine in Hamlin County, along with others such as Grant County, Lincoln, Minnehaha, and others. So I would ask for your support of this reversion for Senate Bill 236. Thank you.
Thank you, Mr. Lyseth. Is there any further proponent testimony in the room? Seeing none, we'll go to opponent testimony. I'm now calling for opponent testimony for Senate Bill 236. Welcome. If you'd you get the button and then introduce yourself, that'd be great.
So I'm kind of on the fence on this. So let me be very clear. Thank you for letting me speak. My name is Tony Ventura. One thing I see is a lot of this money is distributed through the county commission, and I would rather see the money go to the townships. So the commission gets their money, the township gets their money, and any leftover funds that they have at the end of that cycle, I think the township should be able to use for roads and bridges. As long as they can account for where the dollars are being spent, the money is appropriated, the money should be used for those townships. That's why I'm here. Thank you.
Thank you, Mr. Ventura. Further opponent testimony. Is there any opponent testimony in the room? Seeing none, we'll go to rebuttal. Did you want to yield, Senator Roll?
Mr. Chair, members of the committee, Michael Lindgren, South Dakota Association of Towns and Townships. I do just want to clarify we aren't amending the program as it exists today. We're satisfied with that structure. And that structure does allow the county commissions to be kind of the arbiters of these dollars, so the townships can then apply for those dollars as needed on an as-needed basis for the projects that are available. We don't have any problem with that. In fact, we identify that as a feature, not a glitch. We like the local control element of the RAVE program. I think that's one of its strengths. And so we would ask you to support this legislation because I think it only makes it stronger. Thank you.
Thank you. Close the public testimony period and go to committee questions. Are there any questions on Senate Bill 236? Go ahead, Senator Nelson.
I got two questions here. First one, and I don't care, it doesn't matter who answers it. Just to clarify, do all counties get the same amount of money, or is it based upon the need and projects that they have within the county?
Michael Lindgren, South Dakota Towns and Townships. Mr. Chair, so it is a proportion based off of the available projects. So back in 2021, the total appropriation was $6 million. $3 million of that was specifically earmarked for the Department of Transportation to lay out all of the eligible projects under the parameters of the RAFE statute. And so based off of that inventory, your total the total proportion of the appropriation that your county gets is dependent on how many of those structures were identified in that study, and then if there are new structures that come into existence, those are supplemented.
So if it's based on need, again, you're probably just gonna have to guess here, but why is there so much money? If there's needs and there's projects that need to get done, why do counties have so much money in the coffer that need to go back to the this fund?
Mr. Chair, I think I don't want to speak for anybody. Like I said, there are absolutely counties that had, I think in some cases they would tell you decades of projects that they just didn't have the money for. This was a breath of fresh air. They needed it bad. Those accounts were zeroed as, quicker than anything. I think there are other counties that, for maybe a couple different reasons. One is that they may have had some pre-existing funding that maybe they weren't in as much need, which isn't to say there wasn't any need. I think the other element, and this is probably the more likely case, is some of this comes down to educating the townships of the availability of these funds. I was eavesdropping a little bit on your conversation earlier. I apologize. But a lot of this does come down to making sure that the townships have the knowledge that these funds exist. We work very hard to provide that knowledge. There's still work to be done there. So I think more often than not, when you have these these counties that are underutilizing the funds, it's probably more to do with the fact that the townships are not yet aware that it exists. And I would go one step further in saying this bill on purpose acknowledges the existing reversion date, which is 2029. We don't want to play with that too much because, in our opinion, giving people time to become aware of the program, utilize the funds, and if it truly becomes a point where, I'll pick on Brookings County, if they've got money left over and there's just nothing else they can spend it on, we don't want that money to go back to the state because even though Brookings County is settled, we've still got problems in Hamlin that we've got to settle. And if on that cycle Hamlin solves all its problems, well, then maybe my hometown, Coddington's got something we got to address. And so there's a lot of lives this funding can live before it's reverted to the general fund, as opposed to a more traditional appropriation, which kind of one hit and then it's done.
Any other questions? Seeing none, I'll move from questions to action or discussion or action.
Mr. Chair.
Senator Whip.
I move a due pass recommendation for 236 as amended.
Second.
We have a motion, a due pass motion on Senate Bill 236 as amended, made by Senator Whiff, seconded by Senator Roll. Comments on your motion?
No.
Are there any other comments on the motion?
I just guess I would say, Mr. Chair, I think it's good planning, and knowing that you're such a big Brookings guy. He was joking. We would never take money from Brookings County. That was not a factual scenario.
Any other comments? You know, I do appreciate this bill because I do think money needs to be redistributed where there's need. I just do know Brookings used all theirs up because they were ready. They had the plans ready to go, and they were very good users of these funds to improve the roads. So with that, we have a due pass motion for Senate Bill 236 as amended. Those in favor will say aye. Those opposed say nay. Madam Secretary, please call the roll.
Senators Nelson,
Aye.
Roll,
Aye.
Shanefish,
Aye.
Smith,
Aye.
Whiff,
Aye.
Duhamel,
Aye.
Reed.
Aye.
Mr. Chair, we have all yeas.
Thank you, Madam Secretary. Senate Bill 236 as amended will go to the floor with the due pass recommendation. Since we had soft opposition, I think I'll put it on consent unless there's a concern with that from the committee members.
I think it can go on consent, knowing that I mean, obviously the opposition is opposition, but it's not opposition to the bill. It's to a problem
The program.
in the original system.
Yes.
Yeah.
Any other? Okay, so I'll certify that on consent. We'll now move on to Senate Bill 237. This is an act to establish additional notice and hearing requirements for applicants seeking conditional use permits for proposed uses that materially affect public infrastructure or right-of-ways. I'll call for proponent testimony.
Mr. Chair, I have an amendment I'd like to move.
Is it 237B?
Yes.
Oh, okay.
And I'd second that.
Okay, so we had a motion made by Senator Smith, seconded by Senator Roll to move 237B. Does everybody have that? It's a hog house, so I want to make sure everybody has. Okay, everybody good with it? Any comments? Seeing none, all those in favor of the amendment 237B will say aye. Aye. Opposed? You may speak. The amendment passes, and you may speak as amended to the bill as amended.
Fantastic. Thank you, Mr. Chair and members of the committee. Senator Sidney Davis, District 17. Appreciate moving that amendment. That amendment was a big effort of ongoing conversations between a lot of stakeholders to try to find some common ground and come to in my opinion, a great resolution. And so that ended up with Senate Bill 237 as amended. And so we know our state continues to grow for a variety of reasons. We respect property rights, we welcome private investment, and part of that is because we also want to maintain a predictable regulatory process. And so Senate Bill 237 is trying to strengthen that predictability. This bill would establish a standard 10-day township notice that would be required for conditional use permits in South Dakota. So when a project has the potential to significantly impact county roads, drainage systems, utilities, or other shared public assets, it's important that the right people are informed early and they have an opportunity to weigh in. And from a developer's perspective, certainty and transparency are advantages. Projects tend to move more smoothly when expectations are clearly laid out in the beginning. And that's for a variety of reasons. We can identify maybe infrastructure concerns and address them up front, and then there's less risk of surprises later for folks, whether that means public opposition or costly redesigns or legal challenges. So by ensuring proper notice with this bill should help surface those potential issues early in the process so that they can be resolved more efficiently. This legislation also protects public investments. Counties and townships maintain thousands of miles of roads and critical infrastructure with very limited budgets, as I know you guys have been talking a lot about already today. When a proposed use affects those systems, it's reasonable to have a timeline in place so that we can evaluate maybe what the impact might B. So by doing this protects both taxpayers and then also the project applicants by ensuring everyone's operating from the same set of expectations. Again, just as a reminder, this bill is a culmination of some extensive work and discussion amongst passionate stakeholders and leaders across the state. The resulting language represents a compromise that I feel is in the best interests of those most affected by the permitting process. So ultimately, I believe this bill promotes responsible growth, it builds trust in the conditional use permitting process, provides clarity to applicants, and ensures that our infrastructure considerations are handled in a fair and transparent manner. So when communities feel heard and infrastructure impacts are addressed proactively, projects are more likely to move forward in an efficient and timely manner with long-term support. And so with that, Mr. Chair and members of the committee, I'd ask for your due pass recommendation on Senate Bill 237, and I'll stand by for questions. Thank you.
Thank you, Senator. Further proponent testimony for Senate Bill 237. Proponent testimony.
It's Township Day at the Capitol. Michael Lindgren, registered lobbyist for South Dakota Association of Towns and Townships. I'll be really brief. I think Senator Davis did a great job of kind of rounding out the need for this and the advantages. One thing I would just highlight is right now there is not a standard notice requirement in the state. Some are utilizing 10, some are utilizing less, some are utilizing more. There's a lot of uncertainty, and as Senator Davis alluded to, this bill in its current form is really the product of a lot of really great conversation and a really productive compromise to at least take a first step to setting a standard for all the parties involved. We would ask for your due pass recommendation today, and if you've got any questions, I'm happy to answer them. Thank you so much.
Thank you. Further proponent testimony for Senate Bill 237. Welcome.
Good morning again. My name is Chris Jacobson. I serve as Executive Director for the South Dakota Association of County Commissioners, and we were one of the stakeholders in the discussion of this bill and would encourage your favorable support of Senate Bill 237 as amended.
Thank you. Is there any more proponent testimony in the room? Proponent testimony. Okay, so I'll move on to proponent testimony online. And I think we have Mr. Lyseth. I think you're on this bill also.
Yes, Mr. Chair and committee members, this is Dustin Lyseth with the Vice President of the Towns and Townships. Just want to share today, townships are asking the state legislature to help improve the county zoning and planning process with townships when it comes to conditional use permits in their county. Townships are seeking a direct advance notice of conditional use permit applications, not the same notice given to the general public as published in a local paper where citizens may or may not subscribe to that paper, mainly because not everyone in the county has the subscription. So as the conditional use permit requests have changed dramatically in size and scope in this past decade, my example would be a dairy isn't 500 cows anymore, it's 10,000, maybe up to 25,000 cows now even. These CUPs are now hundreds of millions of dollars, if not $1 billion investment. Demand local infrastructure, specifically township roads, is not being considered in several cases with enough importance. And how can a township board determine if there is or is not a need for a road haul agreement or a road use management agreement with a developer with no time to hold a meeting with that developer? Townships just want to be informed and educated by the developer prior to a CUP hearing rather than at the county zoning and planning hearing. This is a positive step towards successful economic development. I'll close with this. Community development before economic development equals a successful economic development. Community development is the foundation of economic development. This development occurs through community engagement, leadership development, public policy, workforce development and education, quality of life, infrastructure, and housing solutions. These are the building blocks of a thriving community. Once these building blocks are addressed and in play, then a community can fully support a new business, entrepreneurs, and existing business development. This is how economic development should happen in South Dakota. I hope today that you guys can work together and give South Dakotans the best opportunity to live in the state through economic development done the right way. Please support Senate Bill 237. Thank you.
Thank you. Any further proponent in the room? Seeing none, we'll go to opponent testimony. Are there any opponents of Senate Bill 237? If you'd go ahead and introduce yourself again, please, sir.
My name is Tony Ventura. My name is Tony Ventura. Thank you, Mr. Chairman. I think the 10 days is good intent, but I'm just going to go with what I have here because it was kind of thrown in at the last minute and it doesn't really address much. But originally I thought they were giving joint jurisdiction to townships and counties to work together for zoning. I think it's a great idea like cities and counties do. That doesn't seem to be the intention of this bill. It makes no sense on CUP on real property under section 8-2-1 of South Dakota codified law. Anything that impacts township property owners as well as safety roads, firefighting, not addressed as part of the zoning or comp plan, a township has the power right to govern themselves for running zoning or declaring emergencies, which will take over 30 days. So you're sending a letter 10 days, and some people don't even open their mailbox for 10 days in the state of South Dakota. And then if you send them a letter and they have a problem and they want to have a public hearing themselves, it's way past the 10-day deadline of the CUP. So that has to be addressed one way or the other. So you also have negative impacts. So in here it says if an appeal was filed, what legal justifications or ramifications would the township have with planning and zoning because the Board of Adjustment and the commission or the, commission or the township does not have equal power, but they have power themselves under Constitution 8-2-1. And so are we giving them the power to appeal these? And so there's kind of this gray area that's just kind of thrown together. And I think that there was some good things in here, but it's just systemically pasted together where it really needs to be reworked and reused. And so the formulation is just not correct. So the other part about it is they're giving information. If you want to have something about what they're doing, you should have a detailed plan, road usage, traffic count. But I think Smithfield Foods, the new Smithfield Foods is a great example in Sioux Falls. First you build the infrastructure, first you have the land, first you build the roads and the sewer up, and then you bring the project in. Where I live in South Lincoln County, you apply for a CUP, they approve it, and then they just rip these roads to shreds. And so that's the problem, I think, for the townships. And I speak for a lot of townships in my area. I'm not on a township board. But I am adamantly for landowner rights and protecting them. And the closest the government to the people is the township. And so when these notifications are being done, how are we doing that in 10 days? So thank you for your time.
Thank you. Further opponent testimony? Opponent testimony on Senate Bill 237 as amended. Seeing none, I'll call for rebuttal. Sure. Come on up, Ms. Slagan.
Mr. Chair, members of the committee, Michael Lindgren, South Dakota Towns and Townships. Couple things. First, I appreciate the comments from the opposition. I would just highlight, I think there's a proverb about the best kind of compromise is when nobody gets everything that they want. If you look to the original language in the bill, we came in with kind of our high water mark. We had really, really good conversations with everybody at the table, and we landed here. I don't think this is where the statute will be until the sun burns out, but for the sake of moving the ball forward and getting a standard foot in the door so that we can keep having this really important conversation, I think this is a great first step. The second thing I would say, and I'll leave with this, I think when we start talking about conditional use permits, we get caught up with big gravel pits and limestone mines and Smithfield, and those are all very serious problems. But I'd like to zoom out a little further And what we're really talking about is making sure that project applicants are aware of things on a very basic level. I'll tell you just a really brief story to illustrate the point. There was a church trying to build on a parcel of land outside of a township, and they needed to utilize a township road. Without notice, that township wouldn't have been able to tell that church that was going to get built in a perfectly legitimate way, in a perfectly legitimate parcel of land, that that township didn't plow that road regularly in the winter. And so you're going to have a lot of people that didn't make it in the pew on Sunday without that kind of notice. Fortunately, in that specific instance, there was a notice requirement, so we didn't have to worry about that. But I think it's really easy to get caught up in the really big stuff when a small step like this can do a lot of good for some of these smaller projects that are just as important, if not more. So we would urge favorable support. Thank you so much. Please vote do pass.
Thank you. We'll now move on to questions. Do you have any questions on Senate Bill 237 as amended? Go ahead, Senator Nelson.
Thank you. You can go back to the hot seat there, because I think that you'll answer these, A couple questions I have here. First of all, when you say county, a county shall provide, who, when you say county, is that the planning and zoning director? Is that the board of the county commission board? Is it somebody else?
I might have to phone a friend on that one. I guess I don't want to speak to the counties. It would be to, I think on a county by county basis, I suppose who exactly the notice comes from would probably be up to the county commission. I mean, it would be the county commission would be responsible for it ultimately. But whether it's, Steve Smith or Joe Hansen, I think that will be largely up to their discretion unless the county auditor. Final answer.
Okay, Mr. Chair. And then also to clarifying written notice, what does that mean, like a hand-delivered letter? Does that mean like certified letter? Does it mean like just putting a letter in the mailbox? Is it like going to their house? So, because the reason I ask that is 10 days is pretty tight, because I mailed a letter to somebody on the 30th of December. They did not get that letter till January 15th, and they live in Yankton.
Yep.
So what do you mean by written notice?
Great question, and that was something that had come up in the course of discussion. I think if you go to kind of the original language of this bill, I think we had specified certified mail. Exactly to your point, Senator, the concern in that was that we don't know how long it's going to take for a letter to get there. And we also wanted to accommodate the fact that in the digital age, emails exist, text messages exist. As long as there is a written record that notice has been furnished to the officers identified in the bill, that's what we're primarily concerned with. And so we wanted to create as much opportunity to furnish that notice timely and with efficient use of time as possible. So written is to be read in the most expansive use of the word.
Okay, one last question, because one thing that was said is that this is mainly for projects, roads, right-of-ways, deteriorating the roads, things like that. One thing that concerns me, and I'll just ask you this if you've thought about this, is the fact that in my case, for example, up in Yankton, where we were having the wind turbine company coming in, it affected, even though, it affected more than one township. And I know with these dairies that have come in and Lincoln and stuff, it may be in one township, but they're hauling manure and feed trucks and stuff. It affects more than one township. And so I noticed here it says located in the township, but you're not saying, the affected townships by roads and hauling. So I was wondering if you'd thought about that.
Mr. Chair. We did, and again, I would kind of defer back to the compromise language that we ended up with. We wanted to paint with a pretty broad brush in our amendment. If you look to the amendment that we've posted, we had originally started with language that would concern whether noticeable deterioration had happened to a given asset, what constituted an effect on a given piece of infrastructure. The reality is, for the conversation that we're having today, that's pretty deep in the weeds. And so when we posted our amendment today, the goal is to paint with as broad a brush as possible so that we don't really have to concern ourselves in the immediate term with whether or not playing referee on whether or not something is deteriorated or materially affected or not. We defer to trying to paint with as broad a brush as possible to avoid those conversations, at least for the time being.
Further questions? I do have one if you want to stick around. You know, the original bill, of course, had the Hall Road agreements in. So is there still a process for doing those Hall Road agreements?
Mr. Chair,
go ahead.
There is currently nothing preventing a township from furnishing notice to counter notice maybe to the county and saying we think a Hall Road agreement is necessary or prudent in this case. The ultimate authority lies with the county. And this maybe also goes to the opponent testimony that I didn't cover in rebuttal. We have no interest in zoning authority calling balls and strikes on these projects. We just want an opportunity to raise our hand and say, hey, this is what we think would be prudent. It's going to be the county's call at the end of the day, one way or the other. And so though there is no specific requirement to allow for that in the statute, that is not prevented by the language of the bill as it exists today.
Thank you. See no further questions. Move into discussion and or action on Senate Bill 237 as amended.
Mr. Chair.
Senator Whip.
I want to thank the senator for bringing this bill, getting the different parties to the table, and sort of having this conversation. I feel really good that we're able to get to a place on this where I'm very comfortable with the bill that's before us now. So I'm going to move a do pass recommendation for 237 as amended.
We have a motion to do pass on Senate Bill 237 as amended.
Second.
We have a second from Senator Shane Fish. The original motion was made by Senator Whip. I think you already had comments on your motion. Are there any other comments on the do pass recommendation?
Mr. Chair?
Go ahead, Senator
I make
Nelson.
a substitute motion.
Sure.
I make a motion to send Senate Bill 237 to the 41st day.
We have a motion to send Senate Bill 237 as amended to the 41st day. Seeing no second, sorry, that fails. And we're back to the original motion. Any more comments on the do pass recommendation for Senate Bill 237? Go ahead, Senator Nelson.
Yeah, I have a couple comments. I mean, I was kind of shocked by the difference in the bills, the amendments, and it kind of was, personally, the first one was, it was concerning just to go from, went from this down to this. And it was very concerning. And I just don't think Senate bill, don't think this is ready. When you compromised, you lost a lot of details in it and stuff like that. What concerns me is what you said about I would like to see who provides the notice. I'd like to see that in there to say who is the person who actually does that. The second thing is written notice. What constitutes a written notice? I don't think an email, when we're talking about projects that are going to affect our townships, I don't think an email does the job. And so, something, certified or something that really makes sure that it gets to the person. And also, too, the fact that these projects that we're talking about, damaging roads and stuff, affect more than one township. They can affect 2, 3, many more. And so I think not just a township where the conditional use permit is going to be, enacted, but also any township that will be affected, whether they're hauling stuff, things like that. So just some things that I would like to see in this, and so I will be resisting this motion.
Thank you, Senator. Further comments? So I'll make a comment. I understand what, I guess what I'll say is it's great to have the town and townships on board with doing this. I think it's a good start. I agree with that. I feel this will have to grow into the future, but at least you came to the point of there has to be notification for this, and then I think either in practice or as it grows, I think this is something that may need to be worked on. So that's my comment. I will be supporting the do pass motion. So we have a do pass motion on Senate Bill 237B. All of those in favor will say aye. Against, nay. Madam Secretary, please call the roll.
Senators Nelson,
No.
Roll,
Aye.
Shanefish,
Aye.
Smith, Whiff,
Aye.
Duhamel,
Aye.
Reed.
Aye.
Mr. Chair, we have 6 yeas and 1 nay.
Thank you, Madam Secretary. Senate Bill 237 will go to the floor with a do pass recommendation. That's the end of our calendar. Anything for the good of the order? If not, oh, go ahead, Senator Roll.
I'd make a motion to adjourn.
Motion. Oh, we'll pause just for a minute. No, there's no meeting on Friday. Yep, I will be canceling Friday. We have no more Senate bills. These are our last 2 Senate bills.
You guys
With
just gonna
that-
leave me hanging? No second?
We have a motion to adjourn from Senator Roll, a second from Senator Shanefish. Thank you. All those in favor will say aye. Aye. Opposed? We are adjourned.
From children's programs to in-depth documentaries, SDPB sparks curiosity and lifelong learning in every South Dakotan. SDPB. Good, useful, and full of wonder. SDPB brings South Dakotans together, telling the stories that unite small towns, big ideas, and the people who make our state shine. Good, useful, and full of wonder. SDPB. SDPB shares the voices and experiences of South Dakotans, preserving our stories, our culture, and our sense of place. SDPB, good, useful, and full of wonder.